Okay, I think if it's okay with everyone, I am going to get started. My name is Earl Hirsch. I am sitting here in my office at the University of Washington in Seattle, where it is 39 degrees right now, which is a good thing. The sun is coming up here. And we're going to talk about interpreting diabetes downloads. This is going to be a relatively brief review. I hope it's helpful. And we will have time for a few questions which you can answer through the WebEx under the Q&A, and I will try to get to as many as I can when we are done with the presentation. So I think the first thing we need to do is talk about basic definitions, because I want to make sure we are all on the same page. The downloads are getting better in terms of being more standardized, but they're not all completely standardized. I don't think I need to review for this audience what an average or a mean is and how it is calculated, but it is important to know that many of the downloads look at the average and the median. And this is actually important because when the average and the median are far apart, and that defining far apart is different for different people, but that means you have more outliers and more variability. The standard deviation is what we have used classically over the last 25 years or so, looking at variability of glucose. Specifically, we use that quite a bit with meters, but we are now moving from standard deviation to coefficient of variation. And it's important to understand coefficient of variation, not so much how it's calculated, which is on the slide, but more so what is a good one, what is a bad one, what are the targets for that, and so forth. And we'll get to that in just a moment. And then the final point here is something called the Glycemic Management Indicator, or GMI. And this was developed by Rich Bergenstahl and Roy Beck and a few other people who are working with the T1D Exchange and the JABE Center, looking at large numbers of people with both type 1 and type 2 diabetes, comparing their A1C that was measured to an equation that was calculated. And it's very interesting because it shows there's quite a bit of variability with everybody's A1C. And we've known that here in our clinic for a long time, but it's quite interesting, and I'll show you that in just a moment. What not all of the downloads do yet, but they will eventually all get there, is calculate the GMI. But actually, you can just go to a website with your CGM, your continuous glucose monitoring average, and actually go to this website, which is jabe.org/GMI. You put the average from the CGM in. Ideally, you have 14 days. 10 days is still okay, but 14 days of CGM data is ideal. And you just press calculate, and it gives you what that hemoglobin A1C should be. Now, the GMI used to be called the estimated A1C, and it was actually the US FDA that really were the ones who said we can't use estimated A1C anymore. A lot of reasons for that. We now use GMI, but it's important because when you have a discordant GMI compared to a calculated A1C, you sort of want to know that. You want to know that you really can't use the A1C the way we would classically use it, to know if you're going to add a drug in somebody with type 2 diabetes, if somebody's ready for pregnancy, and so forth. And that is why we are moving more towards time and range. And so time and range is actually, by definition, from a consensus conference that we published a couple of years ago, defined as 70 to 180. And so therefore, time below range is, by definition, less than 70. And we call severe hypoglycemia time below range less than 54. So time above 180, we call time above range. And based on a lot of data, which we don't have time to get into now, for the majority of people with type 1 and type 2 diabetes, our target for this time and range is above 70%. Many of the pediatricians really had trouble with this when we had our consensus, because for many of the children and adolescents, They were so far away from that, they thought it would really be difficult from them emotionally when they saw how far away they were from the target for time and range. But there's actually data now with retinopathy and nephropathy to really support this greater than 70% time and range for most people. By the same token, the time below range, we want for most people less than 4%. And to put this into perspective, every 1% is 15 minutes. And what that means is we want your time below range to be less than 4% or an hour a day. And you'd be surprised how many people are hypoglycemic more than an hour a day when you look at the CGM tracings. And you really want to avoid the dangerous hypoglycemia less than 54. So that for most people should be less than 1%. On the other hand, when you have older, more frail or high-risk patients where we are really concerned more about hypoglycemia, in this population, we want the time below range to be our primary goal, less than 1%, and the time in range, TIR, if it's greater than 50%, we are pretty satisfied with that. But these are the major guidelines. There's the reference for you from earlier this year. And if you want to learn more about our targets for time and range, I really encourage you to go to that reference. This was an article, it actually was published recently, looking at a variety of different studies in type 1 diabetes and looking at time and range as it compares to hemoglobin A1C. And I want to show you that for an A1C of 7%, that would be a time and range of right about 70% time and range. Almost the exact same data was seen for type 2 diabetes, but this is actually important when you look at the spread and how widely variable the A1C is compared to the time and range. And what we have here are data from our clinic in Seattle showing that the measured A1C compared to the glycemic management index, the GMI, we have shown that for more than 1 percentage point away from the GMI and the measured A1C is 31% of our population. So that is a lot of people, which is why, at least in my view, it seems to me CGM has really helped us and helped us with really understanding so much more about the diabetes, including understanding many of the problems we have with hemoglobin A1C. So the ambulatory glucose profile, which has become the standardized way to look at this, the pictures of how the glucose levels look, has been quite helpful. This one happens to come from a Dexcom, but they all show pretty much the same thing. With this ambulatory glucose profile, the orange line is the median, and what you see with the blue is 25% above and 25% below. And you can see at the different times of day, you can see how the variability changes based on where you see the blue. The dotted line is where you see the upper 90th percentile and the bottom 10th percentile. So most of the patients are, most of the numbers from this, whether it's for 14 days or whether it's for a month, you can get a very good idea where the patterns are when you look at this. Now, the other thing is you can actually look at the numbers. You can look at the average. You can look at how much they are actually wearing their CGM, and you can look at the variability statistics. Now, there's a bit of a controversy in my view. There was a study published a few years ago from France saying that we should call the diabetes unstable with a lot of variability if the coefficient of variation is above 36, and the goal should be less than 36. But in my view, when we've looked at so much data over time, I actually think that the coefficient of variation target should be less than 33, because certainly the lower the coefficient of variation, it's not only the variability with the ups, I'm more concerned about the downs. And once you get to a coefficient of variation less than 33, you almost will always have your target in terms of hypoglycemia. The time and range in this patient meets the target of above 70, but this is the problem with this patient. He has a coefficient of variation above 36, so not surprisingly, his total time less than 70 is above the target at 5.6%. But what's nice about this is that we have these metrics. This is pretty much standardized on all of the CGMs, and we can tell the patient right away where they are in terms of where they should be based on our international guidelines. So here's this individual has a GMI of 6.6%, and the question is, where is the measured A1C? Well, here's somebody else. This is a 24-year-old woman with multiple injections on a Dexcom. She's had her diabetes for 14 years. You can see her GMI. Her estimated A1C, which we used to call it, or GMI now, is 6.6%. But her actual measured A1C is 8.2%. This is an actual patient of mine. And I use the terminology discordant if the GMI is more than 1% away from the measured A1C. And in her case, her A1C was reading off because she had iron deficiency anemia. And with iron deficiency anemia, this is one of the rare causes where we understand that there is a higher measured A1C when there's iron deficiency. Interestingly, most other anemias, you will see a lower measured A1C compared to the GMI. Here's another one, and this is also very interesting to me because it's the opposite of what you would think. This is a woman with type 2 diabetes, non-proliferative retinopathy, diabetic kidney disease. In December of 2017, her A1C was 8.3% when she was diagnosed with her diabetes. Her internist started her on low dose of a sulfonylurea. She actually got more fatigued, especially in the afternoon, and she had relatively severe CKD with an eGFR of 24. So she was referred to me, and I did a Libre on her, a Libre Professional. Her A1C at the time was 7.7%, and I want you to look at this. You can see her time in range, but I want you to look at her hypoglycemia, 25%. Now her GMI with that average of 99 would be 5.7%, yet her measured A1C at the time was 7.7%. So she certainly had a discordant A1C, but it went the opposite way as you would think for her CKD, where you would think her measured A1C would read lower. Hers, for reasons we don't know, read higher. So she was hypoglycemia a quarter of the time. I mean, that's over, what, 4-6 hours a day hypoglycemic. I mean, it's too much hypoglycemia. So I stopped her glimepiride. I saw her back. Interestingly, her A1C didn't change off the glimepiride, and here she is a few months later. Now she's 88% in target, a little bit below target, not significant, and her average is up to 131. Now her GMI is up to 6.4%. But you can see how without the continuous glucose monitoring and understanding this, there was no way to really treat this patient appropriately. And she remains now on no medications at all for her diabetes. She's on diet to this day. I just saw her. Here's another interesting one. This is a 45-year-old woman with type 1 diabetes diagnosed at the age of 21. She had quite a bit of hypoglycemia during her 2 pregnancies. And the question is, what is her diagnosis? You can see her AGP. You can see that her average is quite high at 210. You can see that her time in target is 35%. But what's also interesting is she has type 1 diabetes with a very low coefficient of variation, but her average is high. Now, that's not what we usually see. I see this quite a bit in my adults with what I see is she's having no hypoglycemia. She is having hypoglycemia phobia. She is so afraid of hypoglycemia, she's doing everything in her power to keep herself away from hypoglycemia. And this is actually very common with people who have had bad experiences with hypoglycemia. And it's a tough thing to treat, by the way. What about this one? This is a lady on a 670G. And you can see on the left side, she's 75% in target. She has no time below target, which is quite good. And if we look more deeply at her hybrid closed loop, what we see here is that she's only on auto mode with her hybrid closed loop 69% of the time. So she's a bit low with that. We would like that higher. What I also see is that we don't, again, this would be GMI now, not estimated A1C. That just changed this year, but it was 6.9% with an average of 152. That's actually pretty good. What I know with these hybrid closed loops, at least this particular one, is that most of these people, when they do it right, can get to an average of 140. And that's sort of my goal. We don't have coefficient of variation on this, but just to tell you, a coefficient of variation of 33 would be the same as multiplying the standard deviation by 3 and being less than the average. And she made it. So this is somebody who's doing quite well. She doesn't have a lot of variability. Her average is getting close to what the target is for this particular system. But the question is, what should the bolus basal ratio be? Now, what we used to teach over the years is that it should be about 50-50 basal bolus. But what we've learned with this hybrid closed loop and other hybrid closed loops and other technology is the 50-50 ratio is probably not right for most people if they are on an isocaloric diet. And what we've learned is that it's better when the bolus is up closer to 60%. So when I see a bolus less than 50%, I suspect there's a problem. And I can see it here because when you look at the basals, which is the pink down here, it shouldn't look straight across. That means that the basal is always trying to keep up because there's not enough bolus. But I also see something else really interesting here. I see where the bolus is, and I can see she's giving the bolus late, at least there, but I can see this throughout, that she's giving the bolus late and there's not enough bolus. And I can see this all from the download. So she needs a more aggressive insulin to carb ratio, but she needs to spend more attention to the timing of her boluses. And I can see all of that when I look at this technology. So what I did was I made the active insulin time shorter. What that does is that it will give her more correction doses. Now, I know that active insulin time is 5 to 6 hours, but I also know that to make this work the best, because it is so conservative, I need to have shorter active insulin time than the real active insulin time for our rapid acting analogs. What I also did was I gave her more aggressive insulin to carb ratios. Let's look at this one. This is a 57-year-old woman. She had been putting minimal effort into her diabetes for many years, but then last year, at the end of last year, her niece developed type 1 diabetes, and it made her reflect more about her own management. So I actually saw her the last day of last year, and she needed a pump upgrade, and she decided she wanted to move forward with the 670G. And as you can see, she's not doing well. Her average is 217, and she's not checking very much, and her A1C was 8.7%. So she had all of the training. I see her in the spring, and this is what we see. We see that she's in auto mode 95% of the time. Her average is very close to 140. Her standard deviation is very low. It's acceptable. Her bolus amount is close to 60. It's 56%. And she's 84% time in range, only 1% time below range. It doesn't get much better than that. And you look at her ambulatory glucose profile, she looks pretty flat. She looks very good. And then if we get more into the details of it, you can see, and this is what the automated basal is supposed to look like. And you see how it goes up and down throughout the day when she's giving her boluses at the right time and she's doing well. You can also see she's on relatively aggressive insulin to carb ratios. And for the majority of these patients on automated insulin delivery with the Medtronic, I've learned that they do best when I keep their active insulin time at 3 hours. And again, that is for the correction of the glucose, because with this particular system, it only corrects to a glucose of 150. And her A1C, by the way, went from 8.7 to 6.9. That's her measured A1C. Finally, this is a Japanese man with type 2 diabetes. We see a lot of Asian patients here in the Seattle area. BMI is 26, A1C is 7.5. And what I want to show you is, at least here in the United States, is our first smart pen, where we can actually use a bolus calculator into the pen itself, which Bluetooths into an app on the smartphone. And the ambulatory glucose profile looks a little bit different, but it's actually the same as we saw with the others. And for the first time, and this is a big deal for me, I can see what the patient is doing and how the patient is actually giving insulin based on the glucose. Because the CGM data here is from Dexcom, and the Dexcom talks to the smart pen, which is a pen called InPen from a company called Companion. When I see the check marks here, what I know is that the patient gave what the pen recommended for the bolus calculator. But what I also see on this first day, and then I see it again down here on the third day twice, is that the patient is giving insulin well after eating. And of course, that is a recipe for disaster, because that is what I'm finding out to be the biggest problem with these multiple daily injection patients where we have a smart pen. But this smart pen has, I think, been very helpful. We're going to get many smart pens over the next few years. Again, it works on the app on the iPhone or on the Android. And again, it talks to the Dexcom. And we can actually look at a lot of data with this smart pen. It works on the phone. I like to have it downloaded to be in the chart, but even without doing that, you can just look at it with the patient on the phone and look at the downloaded data, so you don't have to spend any time at all looking at things. Looking at these insulin details, this has been my biggest gap as a clinician, looking at people's insulin who are not on pumps. I can actually see what they're doing and even what they're thinking. So to summarize, each clinician needs to know how to dissect and interpret their pump and CGM, and now we can look at even MDI patients for the first time. Each pump and CGM reports are slowly becoming more standardized. Passive downloading to phone apps is here, and this will grow. Our inability to help MDI patients to track their insulin electronically is ending. And I think in the next year or two, as we get more and more of these smart pens, this is going to be the biggest change in the way we manage our patients. All clinicians need to be comfortable with these glucometrics of GMI, time and ranges, and coefficient of variations. And with that, I went through this very quickly. I am going to open up my Q&A, and we'll be happy to take a few questions if there are any. Here we go. This came through something else, a webinar chat. What impact does low use of closed loop on 670G have, and how can we improve that? Yes, that is a really important question, because to really get the best benefit out of anything, you have to use it. I mean, we saw that in the JDRF sensor trial, which we published now, 11, almost 12 years ago. And that is, if you don't use it, it's not going to work very well. I have several thoughts about this. The 670G is our first generation. And we have, if you look at the data that's been presented at various meetings, including the last ADA scientific sessions, a lot of people just stop using auto mode because of the sensor. And it's a lot of work. And it is, you have to do a lot of calibrations. It goes off and alarms at the wrong time. And I'll make a generalization. The people who are used to keeping their A1Cs close to 6%, now I'm talking about adults because I don't see children, they really, really struggle with this. They don't struggle so much with some of the burden of it, but they struggle with the fact that it's hard to get their average below 140 if they play by the rules. Having said that, the people I see with A1Cs above 7.5, 8, 8.5, 9, they absolutely love this, because what happens is one of the main reasons they don't do well is they forget their boluses. And as long as it doesn't kick them out, they the automated basal will keep on pushing them, and they will get they will get insulin even when they don't bolus, and it will bring them down. And I see this over and over and over again. And these people who come in not doing well with their diabetes, in my view and in my experience, they are the ones that benefit the most from this. How to keep them on if they won't stay on because of the sensor or because of the burden, I don't have a good answer for that other than to say the technology is continuing to improve both from Medtronic and others. As far as GMI, glycemic management indicator, again, it's the way that we look at what we used to call estimated A1C. My friend Jerry Fisher from San Antonio, I don't know how the Spurs are going to do, but the question is, how will the approval of Novo's fast-acting affect the data interpretation? The upcoming Control-IQ has a fixed insulin action time. How to shut impact, how would that impact my approach? Well, this is really good. First of all, the FIESP isn't going to affect the data interpretation at all, simply because it is not as fast as perhaps many of us would have liked. And I don't think it's going to have any impact, the fact that, and I don't have any experience yet with the Control-IQ, but I don't believe that changing the active insulin time or not changing it is going to matter as long as it is fixed. It only makes a difference with the Medtronic one because that's how it is used for calculating the very conservative correction doses, which you have to correct only to 150. You can't change that. And that's why we try to make that active insulin time shorter so patients can get more insulin and they're less apt to use fake carbs. That's very specific for that particular pump. My friend Kat, that's really helpful, thanks. Another one, how do you manage expectations with CGM AID data in terms of people chasing the flat line? Wow, always great, great questions from the UK. That's right on, and you're right. We do have people who have unrealistic expectations. I think that's always the case when there's new technology. I think, and I don't want to pick on any particular company, but I do think that technology is often oversold to patients, and then there's disappointments. We've seen that over and over and over, really going back 20, 30 years. So your point is a very good one. And patients have to realize that always getting that flat line is not going to be possible. The one thing that many of my patients have figured out on their own, even though we've talked about it, the two things that patients have to do to stay flat or not have these giant spikes. And number one, they can't give their insulin after they eat. And they do that, and they do that all the time, and that is not going to work. But the other thing, which is really interesting to me, it's the amount of carbohydrate eaten. And you can eat the same amount of carbohydrate in a day if it's in small meals over the course of the day. And we see this all the time in our women who are pregnant with diabetes. They don't eat the large carb meals because that's going to cause the spikes. And that is really between the high carb meals and the timing of the insulin. Those are the two things. And by the way, that doesn't matter if you are on automated insulin delivery or not. But with the automated insulin delivery, it is easier, in my view, to get flatter lines than you do otherwise. And again, I think the upcoming technology will only make that better. My friend Dr. Fisher says, go Spurs. Thank you. Someday we will get NBA basketball back in Seattle, Jerry. I don't know when. And I think that's it for the questions. And I have 8:01 Pacific time, which means my clinic is starting. And I hope you all found that helpful. I'm passionate about this topic because we have so much data here. And what I know is that not a lot of clinicians are taking advantage of everything that we have available for us for looking at data to help our patients. So thank you all very much. This was fun for me. And for those of you in the States, have a great day. For those of you in Europe and in Israel, have a good evening. Bye-bye.